that diffuse mid-wall that we would see in hypertrophied segments in HCMs. Systemic hypertension, sometimes it creates a dilemma. Systemic hypertension would lead to or would cause the concentric symmetrical hypertrophy of the left ventricle, sometimes dilatation and reduced or sometimes reduced function. As you may remember, we mentioned earlier that it depends on the type of sport. So if it's an endurance sport, then we would expect dilatation. If it's a static sport, then we would expect hypertrophy but no dilatation. Mild to moderate dilatation is accepted in endurance sports. Low normal to mild reduced systolic function is accepted in athlete heart. So how could we tell whether there is hypertension? Of course, clinical wise, if there is systemic hypertension, then it has to be treated and then maybe a follow-up after treatment to see the reduction in the wall thickness. But in hypertension, hypertrophy is present. Sometimes the dilatation, hypertrophy, both of them are present, with sometimes a low normal. So it's not correlating with the type of the sports. Dilatation and hypertrophy sometimes simultaneously are present. Hypertension, again, in the clinical history is important to exclude. Amyloid is one of the cases where there is an infiltration of the myocardium and the interstitial space with the amyloid protein, which will lead to concentric hypertrophy. It might present itself with heart failure. It might present itself with dilatation of the atria and a small ventricular size, which would lead to a small stroke volumes when compared to the athlete with a normal stroke volumes. Of course, on the other side, when it goes to late enhancement and tissue characterization, then we would see the diffuse enhancement of the left ventricle and the subendocardial in the atria. Many cases would present themselves with heart failure, similar to this case on the HASTE, where we could see signs of heart failure and pulmonary edema. ARVC, the endurance sports, as we mentioned earlier, leads to dilatation. Mild to moderate is accepted, usually both ventricles, but there is no wall motion abnormalities. On the other side, in ARVC, we could see the abnormal dyskinesia of the right ventricular free wall, in addition, of course, to the dilatation. This sign of dyskinesia that we would not see in athlete heart syndrome. Where if there is ALVC or involvement of the left side, we would be able to see the late enhancement that is usually in the subepicardial, in the inferior wall, and sometimes it is circumferential, so it is around the anterior wall as well, and in the septum in ALVC. Fabry disease, it might present itself by concentric hypertrophy, but again might present itself with some restrictive pattern or the myocardial fibrosis. Usually on the T1 maps, in the early stage, it's going to present itself with a low because of the intercellular deposition of the abnormal material, so low T1 maps or low native T1. And in the fibrotic stage, then the native T1 map might go in the high levels, plus the stroke volume might be reduced when it compared to be or when compared to the athlete heart syndrome. Let's go through a few cases in order to see how the approach would be in clinical reporting. That is a professional footballer presented with some ectopy on ECG, had an echo and had that showed some dilatation, and then an MRI, and on MRI RVOT didn't show any abnormal wall motions. On short axis and four chamber, preserved function, with dilatation of the left ventricle up to 137 milliliter per meter square, which and of course on the late gadolinium enhancement, no evidence of fibrosis. Parametric maps were normal, 970 milliseconds, and that was reported as normal changes and normal adaptation. A period of detraining was recommended. He came back, and the volume of the left ventricle was regressing after this period of detraining, which confirmed that the adaptation or the changes was all because of the professional training or the regular training. The other case, weightlifting, who presented with chest pain. Those are the cine views, long axis and the short axis. The function is on the low normal. There is some dilatation. As far as I remember, the index volume was around 110 milliliter indexed, and of course the hypertrophy is concentric LVH. Late gadolinium enhancement showed some areas of fibrosis. There was an argument whether these areas of fibrosis are transmural or are they subepicardial. The images are not the best. He was weightlifting, a big patient, so the images were not of the best quality, and therefore there was the argument whether there is a pattern of myocarditis subepicardial that led to the dilatation, because weightlifting is one of the static strengths, so we would expect hypertrophy but no dilatation. However, this ventricle was mildly dilated, plus the subepicardial enhancement. The other campus was, or the other argument was, that this is subendocardial and transmural patches, and there is some increase of the native T1 1300. That was on a 3 Tesla machine. So 55 T2 is considered mildly high, which indicates that was a recent event. So kindly always be mindful of that. Sometimes athletes would use performance enhancing substances. It might lead to aortic dissection or spontaneous coronary artery dissection. So that was the diagnosis, or the differential diagnosis was between spontaneous coronary artery dissection that led to an area of transmural infarction, some vasculitis, or it's a myocarditis on top that had led to, that was the main two differential diagnosis. But I would like to draw the attention to be mindful that to ask in the history or to know from the history whether performance enhancing substance have been used or not. Case 3, as you may see that in this case, that was the first presentation was ectopy while playing football, but was not a professional footballer. Asymmetrical hypertrophy, the images, the 4-chamber, the 2-chamber, and the short axis. From the first view, it looks like HCM. However, what's against is the dilatation, as well as that the function appears restricted and limited or reduced when compared to HCM, where we would see a super normal hyperdynamic ventricle. One is just to draw the attention again, the fibrosis was severe to the burned out HCM. So that was the first presentation, which was very unusual presentation for HCM, burned out myocardium, and we could see on the follow-up that is increasing the amount of the, or the extent of the fibrosis. In summary, or to summarize, athlete heart syndrome accepted some dilatation, mild to moderate, never severe, mild reduction or low normal ejection fraction, no wall motion abnormalities, wall thickness is around maximum 13-14, but does not exceed the 15-16, normal atria, and please always include the history and the clinical data, the type of the sports